Okay, hi everyone, and thank you for inviting us to come and present today. So I'm Laura McGowan. I'm a researcher in the Policy Research Unit in Behavioural and Social Sciences, which is hosted by Newcastle University, and we collaborate with various other institutions. Myself and my colleague Fiona will be talking today about a package of work which we've led within the unit on the implementation of virtual wards across integrated care systems in England. I guess it's not directly social care related, but we will try and draw out some of the implications for adult social care around kind of inequalities, integration, and be really interested to hear where others feel there might be kind of areas of crossover and collaboration as well. Fiona, shall I pass over to you?
Yeah, sure. Thanks, Laura. Yeah, so and just to also add about the Policy Research Unit, we're the Behavioural and Social Sciences, and we work across lots of different topic areas in health and social care. I think primarily the work we've done so far is focused on sort of health and social healthcare and healthcare services and public health, but we are keen to do more work in the area of social care. So as Laura said, it'd be great to kind of identify those commonalities and in common interests towards the end of the presentation. So today we're talking about the implementation of virtual wards in the NHS. So as we already heard from the speakers earlier, the rising multi-morbidity and ageing population is increasing pressures on health and social care services. There's insufficient hospital bed capacity currently, and that's continued. There's also workforce shortages, as again colleagues have highlighted this morning. And there are various policies and plans in place to address some of these issues. So if you click next, Laura, and many of them do include or refer to virtual wards, or also known as hospital at home. Next slide, please. So for those, so just to provide a bit of context, virtual wards is our services, or is an umbrella term used to describe services. And it came about sort of during the COVID pandemic, where there was the NHS England published guidance and mandated the kind of rollout of COVID virtual wards. So this is the idea of that patients would stay at home and would be monitored remotely using sort of wearable devices such as oximeters, and the idea was to prevent them essentially coming into hospitals. And then, as you can see over the next few years, virtual wards, the concept of virtual wards sort of built momentum, and was they were rolled out for other sort of conditions such as frailty, respiratory infections, and so on. There was additional funding provided, and more guidance has developed over time, and eventually kind of bringing you up to now. So now being to last summer, there's over 12,400 virtual ward beds with occupancy available across integrated care systems in England, and they are very much part of the key policies in sort of shifting hospital care into the community and looking after people in their own homes. So next slide is just to add, so hospital at home, I've often referred to virtual wards or hospital at homes, and Peter has flagged hospital at homes is kind of more historic term used to describe care that's provided to people in their own homes. And the term virtual wards came about, as I say, during the pandemic, where there was this idea to have them tech enabled. So they became known as kind of virtual wards, and there's kind of been a switch back towards describing them as hospital at home again. So just bear in mind, I'll use the term interchangeably, but at the time that we did this research, it was very much focused on virtual wards and the kind of tech-enabled virtual wards. So the definitions provided is to provide safe and efficient alternative to NHS bedded care enabled by technology. So these are kind of really acutely ill patients that would otherwise be in hospital, but they're monitored and cared for in their own home, and this is either through sort of in-person visits, through telephone calls, or through, as I say, the use of technology such as wearable devices, remote monitoring devices. And we conducted this research around the time when the NHS mandate came in, and there was funding available, and there was a real drive to kind of roll these virtual wards out and ensure that this was something that every sort of hospital up and down the country was able to offer in these services. Next slide, please. So as you may have already sort of start to think about, some of the relevance to the adult social care is about this, care provided in homes. There's potential in that there's a reliance on unpaid carers, so people supporting individuals living at home who kind of is their social support, who kind of looks after them. So that's the kind of implications to think about. There's, with the introduction of moving towards more tech-enabled virtual wards or healthcare services, there's a risk of widening in health inequalities. There's concerns around safeguarding and digital exclusion. There's the idea that, these services are a real test for integrated care services. So understanding how these hospital staff, community staff, social service staff may all work together to deliver care and look after people in their own homes is something to also highlight. And as Laura mentioned, there's quite a few commonalities with the themes in the other PRUs that we're on this call today. Next slide, please. I'll pass over to Laura, who's going to discuss the research more detailed. Thanks.
Thanks, Fiona. I'm having some weird issues with flicking through slides and then not corresponding, so please do bear with me if there's a bit of a delay or lag at any point. But yeah, I'll kind of go over what we've kind of done in this research. So it was back in 2022 when we started this. We were asked to do this work on virtual wards, and we aim to explore the acceptability and the feasibility of implementing tech-enabled virtual wards from the perspective of commissioners in the NHS, with commissioners being those who were responsible for the planning and purchasing of health services, and they were tasked with overseeing the implementation plans for virtual wards at this time. So we focused on understanding how adoption and implementation processes unfolded, particularly across time. We looked at the key barriers and facilitators to implementation, and looked at what kind of additional support commissioners felt was needed to aid successful adoption of virtual wards. Okay, so we did a longitudinal qualitative study where we interviewed the same participants at 2 time points about 6 months apart. So our first data collection period was in the autumn of 2022, and we followed up with participants in the spring of 2023, so about 6 months later. And this time point was chosen. Well, we asked commissioners themselves, the interviewees from the first round themselves, when they thought a good amount of time would have passed and implementation would have progressed, and they kind of said, we'll understand more about this once we've got through all the winter pressures and we come into the spring. So it was about 6 months between data collection time points. Because we were working directly with policymakers in quite a fast-moving policy research area, we conducted kind of a preliminary phase of analysis using rapid appraisal methods. So we used rapid appraisal procedure sheets where we summarised key findings after each interview and fed this back almost in kind of real time to our policy customers. And then for our full analysis, we conducted thematic analysis, which we structured within the framework approach. We used the consolidated framework for implementation research, or a behavioural framework. So we used both deductive and inductive techniques within this. So we initially coded to our framework, and then we conducted more inductive analysis, so inductive being that kind of data-driven rather than the theory-driven of the framework, to identify what the kind of key overarching themes in relation to our research question were. Okay, so I'll just briefly give a quick overview of the Consolidated Framework for Implementation Research, so the CFIR as we call it. So it's a framework to understand kind of why a new program or new programs or innovations are or are not successful when they are put into practice. It has 5 kind of interacting levels of influence on implementation. So this is the innovation itself, so the thing, the wider external context, and then so that's the outer setting, the organizational setting as the inner setting, all the people that are involved at all levels of implementation and reception, and then the implementation processes, so the processes that are planned and then carried out in practice. I think Fiona might have talked to this a little bit already, but there were kind of various types of virtual ward models which were being implemented. Particularly, they varied with respect to the kind of level of in-person care that the patient on the virtual ward required. So some were more staff resource intensive, which were kind of more the hospital at home services. And there was the less resource intensive kind of remote monitoring services, which implemented technologies a little bit more. But yeah, a lot of variation in virtual wards kind of across England. Okay, so our participants, we interviewed 20 participants at our first time point. We managed to follow up with 14 of these at our second day collection time point. Our participants came mostly from integrated care boards. So we've got a range of 12 integrated care boards. We had representatives from 6 NHS trusts and 2 academic health science networks. We tried to get a good geographic spread, but we did have a bit of a bias towards the northeastern Yorkshire. And we had a mix of executive, managerial and clinical leadership roles. So we had quite a diversity and allowed us to capture quite a range of perspectives of virtual ward implementation across different organisational and geographical contexts. Okay, so we'll talk through some of the key findings, and I've separated this into 2 kind of key sections. So we've got some of the more data-driven inductive insights, which I'll go through in a bit more detail first, and then I'll relate these back to our framework. Okay, so some of the key inductive themes, so really data-driven themes that were generated were assessing the need for virtual wards, coordination of a systems approach, planning and adapting services, and agreeing programme outcomes. Okay, so looking at the need for virtual wards, many participants expressed a kind of clear need to do things differently with regards to care provision in the NHS, particularly in light of the high levels of demand for unmet demand for hospital beds and for clinician time. So as one participant said, the pressures in secondary care are unbearable. The whole system feels broken. If we carry on doing things the way we've done them, then we're going to get what we've always got, and we've got to do something different. So a real kind of call for change. Commissioners were doubtful that virtual wards would ultimately reduce the number of people being cared for in hospital. And I think there was a bit of confusion about the remit of virtual wards, whether it should be reducing the number of participants, the number of patients being cared for in hospital. And the kind of the doubts were to do with kind of the levels of existing unmet demand, that this would always be, and virtual wards would always be an additionality of service in terms of both the staffing and the associated costs in order to increase capacity to care for more patients. So there would, for every patient that is treated on a virtual ward, that bed would be filled because there's such a backlog of unmet demand. And the mandate for virtual wards to be enabled by technology appeared to instill this kind of illogical approach to firstly identifying tech solutions and then attempting to develop the pathway around this, rather than assessing the pathway needs first and then identifying how the technology can fit into that. So a bit of a backwards approach. and actually some question the need for technology at all. So as one commissioner said, I don't think digital monitoring is the be all and end all. Frightened, breathless patients, they want someone who can come and see them, sort them out if they need urgent intervention. And then in terms of coordinating a systems approach, commissioners described having convened kind of multi-organisational steering groups, but it was felt that progress was sometimes hindered by colleagues in different organisations in the integrated care systems having very different perspectives about what receiving acute care at home in the community looks like. People had very different interpretations of the instructions, and that the kind of acute care didn't really understand the community care world. This was particularly discussed in terms of risk aversion. So community staff were perceived to as being less risk averse than kind of their counterparts in acute environments. Participants also reflected on the language and the terminology used to describe virtual wards, that it was confusing, and it seemed to stem from an attempt to apply this acute care language to community services. So as someone said, we need to stop calling them beds. We need to start talking about caseloads. The notion that you'd have an empty virtual ward bed doesn't really make sense. Okay, so agreeing programme outcomes and goals. It was clear that the most important markers of success for providers were the patient experience, the patient outcomes, as opposed to some of the hard metrics that were being put forward as evaluative measures by the national teams. So as someone said, I think we're so politically driven on a few metrics. We don't think about the long-term perspective, some of those big quality markers that really represent value in the long term for people and for the system. And then the funding model was a very contentious issue. This period of kind of 2 years of funding was thought to be too short to plan, execute, and then determine if a care delivery model, especially one that involves a whole system transformation, is effective. And there were concerns that the kind of lack of time and financial investment given to virtual wards could lead to the national team overlooking something which really has promise but hasn't been given the required time to evidence its success. And a quote that always sticks with me is, by trying to do things too quickly with ridiculous punitive measures in around success, I think we could really throw the baby out with the bathwater. Okay, and then finally, planning and adapting services. So I'll go through this quickly, I'm just aware of time. So there was actually lack of understanding of what counts as a virtual ward. It took some people months and months and months to actually understand something they'd already been doing would count as a virtual ward by the then definition. And there was issues around kind of standardization versus flexibility. So where existing community or hospital or home services had already been in place, commissioners reported being involved in shaping service provision less frequently and gave more autonomy to the trusts themselves to develop their own pathways. But this then meant that there was variation across the system in the services that were being provided. And many of the virtual wards didn't actually have tech or were struggling around the tech component of this. Someone had said it had taken 18 months to, deal with all the issues around information governance, the protocols, the procurement processes. And so this really put people on the back foot who hadn't been implementing tech or any kind of remote monitoring. I'm going to just fly through the seductive analysis because I think it's really important that Fiona gets on to kind of what our next steps are. But we mapped kind of our findings onto each domain, and there's a bit of a diagrammatic overview of some of the barriers and facilitators within each domain. I think at first individuals are really important, so that leadership, people driving this change, but over time it seemed that the inner setting became more important, so that ICS level and some of the more system barriers kind of impeded on virtual wards. And some of the key things over time that persisted were that kind of funding, capacity, timelines, patient suitability was a key thing. So that risk of generating intervention, generated inequalities, as Fiona spoke to before. So really looking at the patient's home and circumstances and digital and health literacy. And then that trust between acute and community care staff as well, which I previously mentioned. I'll hand back over to Fiona because this leads into kind of some prospective work that we are working on. There are links to some of our publications here. We did present some of this in Parliament, which was quite exciting. But Fiona, I'll hand over to you. Sorry, I've commandeered a lot of that time.
Not at all, that's fine, thank you. Yeah, so as I say, our Policy Research Unit, we work on lots of different projects, and as we're moving forward to develop new projects, we were building on some of the findings from our work, so drawing upon work in this area of virtual wards, but also from our other studies, such as one around exploring how to widen the acceptability of public health interventions, and through that we identified sort of trust and skepticism, and maybe amongst those with maybe anti-elitist views, and how you know, how these shifts from hospital to community settings and new ways of working with professionals from different integrated services. So we have another study called Optimising Integrated Care Services for Physical and Mental Health. So we've identified some learnings from that project as well. And so we've identified sort of trust and risk as sort of key sort of common themes across much of the work that we've done, and we're looking and guided by the 10-year health plan to understand we would like to explore a little bit further how trust and risk may influence the use and adoption of technologies or these new ways of integrated working in the community a little bit further. So next slide, please, Laura. So kind of building upon that, and we'll be working with policy partners and convening a team of public patient and practitioners to kind of discuss and shape some research questions. But we think there's areas of trust and risk and potential barriers and enablers to new ways of working in different settings and with different colleagues and so on is something that we're particularly interested in. And so that's kind of where we're sort of moving towards next, is developing research in this area. And I suppose our final slide is around inviting anyone on the call, if anyone has any particular interest or can see some commonalities or that you think could potentially build into this work that we're hoping to explore further, then please do reach out. We are very keen to work with you. I think that's slides are a bit stuck, Laura.
Oh, okay.
Thank you very much, Laura and Fiona. So I think we're running out of time, but we have time for kind of a brief 1 or 2 questions if anybody has. Peter, yeah.
I'm mindful I've asked a lot of questions, but I will say this, 2018, I had a heart attack, and that was the last time I was in a hospital until 6 weeks ago. And I was shocked when I went back to that same hospital. By just observing that day and visiting my friend I was only in there 30 minutes, I learned such a lot about some of the stuff you're talking. I think this is a very creative idea. I'll probably be linking into it soon as well, so I'll probably be able to give you feedback on it and how it works. My question is about the AI, and you're right about trust. I think members of the public, the 10-year health plan, the big thing about that is great, but a lot of the points that have been raised for the last 20 years and nothing's been done about it. So a huge amount of trust needs building with members of the public with regards to that. It's about training for people when they're using AI and apps and the implementation of that. I think that's really crucial with regards to that, and just wondered whether that was something that you're going to look at all.
So are you, sorry, you kind of dropped out a little bit there. So is it about, the question is, are we going to be looking at sort of AI and trust in AI in technologies in healthcare?
When you've got patients at
that your
home
question?
and they're given these devices, or they're put on their phone, it's not down to the carers, as in family members, to have to navigate that, which is causing a lot of time delay and causes a lot of hassle. How is that going to be implemented? I think that's something that could do with being looked at.
Yeah, absolutely. Yeah, and we hope to work with patients and carers to get their experiences of how they maybe use these technologies and how they find them, what they think of them, and so on. And similarly, how healthcare professionals and others using such technologies, how they what factors influence their use of them, and is trust and risk a key part of that?
Thank you.
Yeah. Just then the final probably remark from me, if there are no other questions. So I kind of picked one of your remark regarding virtual wards relying on unpaid care and home care workers. So I think, not really, is there evidence already there that this increases pressures and kind of care load for unpaid carers, and how kind of they will likely deal with that? And also how much, I think there is also a question how much this virtual wards would rely on task shifts from health to social care, and then who will bear the cost, who is expected actually to train the staff into kind of to deal with additional tasks, and also potentially an increase in pay for increased responsibility. So I think there are many issues there to explore in the future.
Yeah, I think there's a colleague, I think at Glasgow University, who was looking to do some modelling around virtual wards and the increase in kind of unpaid care. I'm not sure how far that's got, so I'm not sure if the evidence is quite out there yet. But I think certainly from qualitative work that we've done, that there is this kind of fear that it will place more burden onto carers, and actually in some instances carers would prefer to have their cared for in hospital so that they can get a little bit of respite. So yes, I think there will be evidence coming out around kind of the modelling around the burden it places on carers. In terms of the second one, Fiona, are you able to speak to that?
I don't know, other than there's a national evaluation going on, but that's primarily focusing on sort of the quantitative numbers and health outcomes of individuals on the virtual wards. But I know that there has been a big NIHR call specifically for research in the areas of virtual wards, and I know that qualitative research exploring these things is something they're kind of looking out for, but I don't know who's exactly been awarded that funding. But yeah, but hopefully somebody out there is doing that exploration.
Okay, thank you very much then. Thank you very much, Fiona, Laura, all the speakers, and also all attendees. Very interesting discussion. And yeah, I think we have to close now. We're a bit over time. So yeah, see you at the next CrossPRU webinar.